Good afternoon, ladies and gentlemen. We will now begin the SSIS-KLID co-hosted online seminar. Today, the theme is COVID response in Korea and abroad. Since COVID-19, there is a lot of interest and concern regarding the economic and social changes, so we believe this is a timely and important topic. Before we begin the lectures, we would like to first invite President of KLID, Ji Dae-bum, for his welcome remarks. Good afternoon, ladies and gentlemen. I am Ji Dae-bum, President of the Korea Local Information Research and Development Center. Let me begin by thanking all of you for taking part in this online seminar co-hosted by KLID and the SSIS. In these difficult times presented by COVID-19, we have organized this seminar to do our part in the nationwide effort to overcome the pandemic, thus fulfilling our responsibility as both public organizations and organizations responsible for digital services. KLID is an organization that is responsible exclusively for local informatization and leads digital innovation as well as decentralization and local digital innovation. Furthermore, by operating dozens of digital government systems, we provide diverse administrative services directly and indirectly to the people of Korea. Last year, amid the spread of COVID-19, KLID played a pivotal role in the swift and accurate provision of COVID stimulus checks to people suffering from economic loss and hardship, thereby helping to promote consumption and the economy. We are also operating the self-quarantine system, thus consistently contributing to the national COVID response efforts. Globally, COVID still remains a serious problem, with advanced countries like the US and European countries, including the UK, still struggling to come out the other side of the pandemic. However, there are growing expectations of achieving herd immunity with vaccine development and expanding coverage. This is spurring discussions on the topic of the post-COVID era. Korea is actively utilizing digital strategies and tools to overcome the pandemic, perhaps more so than any other country in the world. In fact, this approach is now known globally as K-quarantine. Korea should share its COVID response strategy with the international community and also join in on discussions on how to prepare for the post-COVID era. In this online seminar, in which we are joined by medical and health professionals from home and abroad, we will compare and review best practices in COVID response and discuss the way forward for Korea. After the presentations, we have allotted time for discussions as well as questions and answers, and I look forward to the active participation and engagement of the participants. Furthermore, your active feedback, any requests or advice on the seminar will be appreciated and ensure that we organize more meaningful and helpful events in the future. I would like to thank our co-hosts, SSIS, and all involved once more for their hard work in preparing and organizing this event. Thank you.
President Ji Dae-bum, thank you very much for your opening remarks. Next, I would like to invite President Im Hee-taek of Korea Social Security Information Service for his congratulatory remarks. Good afternoon, ladies and gentlemen. I am Im Hee-taek, President of Korea Social Security Information Service. In this very pivotal juncture as we overcome the COVID-19 crisis and prepare for a new future, it is a great pleasure to be one of the host organizers of today's seminar, jointly hosted by the two institutions leading social security and local informatization, respectively, in the Republic of Korea. I would like to extend my gratitude to Professor Lee Jong-gu of Seoul National University, Health Counselor Nina Monrad-Bohl of Embassy of Denmark in Korea, and Dr. Noralina Binti Nordin American of the Ministry of Health of Malaysia for gracing their invaluable time to present at the seminar. I would also like to express my gratitude to President Ji Dae-bum of KLID for offering his unswerving effort in jointly hosting today's seminar, as well as all participants here with us today. Korea Social Security Information Service, or SSIS, is a central organization in charge of social security information platform representing the Republic of Korea. We engage in informatizing the entire work process of selecting welfare recipients to post-management, and we establish and operate an information system to offer health and welfare-related information to the public. Simultaneously, we are an expert organization that supports government policies. The SSIS is concentrating its organization's capacity to overcome COVID-19 and putting in its utmost efforts to enable the government's disease prevention and control policies be implemented in a timely fashion. In the early phases of COVID-19 outbreak, we established a screening station management system to support swift prevention and control efforts. Also, for infection control of those entering the country from abroad, we developed a self-check mobile application to actively respond to preventing the spread of COVID-19. Also, to swiftly and accurately obtain information on those that visited publicly used facilities, and to have that information be used in epidemiological investigation to counter the spread of infection. In addition to focusing on protection and disposal of personal information, we established and operated the KI Pass, which is an access registration using QR codes, which was an example of the diverse efforts made by SSIS. To overcome COVID-19, not only SSIS, but many organizations, including KLID, is making multifaceted efforts. However, we all know now that based on the past year's experience, that the COVID-19 pandemic situation cannot be solved by the efforts of a single country. In order to overcome this global crisis, cooperation among countries is crucial, and sharing and spreading and disseminating best practice cases of each country and conducting jointly disease prevention and control efforts is paramount. Against this backdrop, I hope today's seminar can contribute to strengthening global cooperation, and I hope the exemplar cases of different countries will be well disseminated so that it can be utilized appropriately based on the circumstances of individual countries. I would like to once again extend my gratitude to all participants, and I truly hope a COVID-free world come to fruition as quickly as possible. Thank you very much.
Thank you very much, President Im Hee-taek of SSIS, for those congratulatory remarks. And now we will begin the presentation session of this seminar. This seminar is comprised of two sessions. The first session is the presentation session, in which we will hear 3 presentations from experts from home and abroad. In the second session, we will have discussions and the Q&A. In this first session, the first speaker is Dr. Lee Jong-gu, who is an MD of Seoul National University College of Medicine. He is the former head of the Korea Center for Disease Control and Prevention, and he is the chair of the Policy Planning Committee's Disease Disaster Response Task Force. Now, without further ado, we would like to invite Dr. Lee to the podium for his presentation. Thank you very much for that introduction. I will be delivering a presentation on Korea's COVID response, and I will be also touching upon the limitations that we have faced in the process. I would like to go to the next slide. Here you can see the overview of the contents. This is a global pandemic, that is sure, but I would like to take a look at whether this is the worst pandemic, and I would like to touch upon what lessons we should learn from COVID. And we need to think about whether this is indeed the worst pandemic of the century, and I would have to say that is not the case. If you look at 1918, there was the influenza pandemic, and then afterwards there was the Russian influenza, the Hong Kong influenza, and then in 2009 there was the new influenza pandemic. And many tens of thousands and millions of people died as a result. So pandemics do happen, and these pandemics do change the world. Scientific breakthroughs are achieved, and sometimes empires collapse due to these global pandemics. What I would like to talk about now about COVID is that in Korea, we seem to be faced with a fourth wave, and globally, perhaps the third wave. You can see that we are seeing a rise in the number of new confirmed cases in Europe and also in the Americas. And we are seeing an increase in Southeast Asia, or actually Southwest Asia. And currently, so far, we have seen 135 million confirmed cases and 2.9 million deaths. Taking a look at Korea now, currently, there is an average of 600 new daily cases. And there are concerns and interest in Korea whether this will lead to a fourth wave. And the number of accumulated cases is around 110,000. And if you look at the number of deaths, it would be around 1,700 since the start of the outbreak. So the death rate is around 3.4 out of 10,000, so it is quite low. And if you look at the death rate, you can see that most of the deaths occur among the elderly, especially those over the age of 65. This is not the worst pandemic. Richard Horton, who is the editor of Lancet, wrote this in May last year. He said that this current pandemic will neither be the last nor the worst global health crisis of the present century. This means that there will be another global pandemic. This is not the first or last. If you look at the first picture on the right-hand side of the slide, you can see that this shows the first ever quarantine station that was established in Venice, Italy in 1348. And on the bottom side, you can see a establishment in Ragusa that was established in 1377. This is in Croatia right now, and it was also a quarantine center. So if you do not have treatment, if you do not have a vaccine for a disease, then you can only manage and control it through quarantine measures. And what I want to say is that if a global pandemic should occur again, then the best or largest tool that we have to control the disease will be quarantine measures. And of course, we have seen the development of COVID vaccines, but there is no known treatment for COVID as of now. So if global pandemics will continue to occur, can we just sit there and do nothing? What can we do? The WHO actually revamped its international health regulation in 2005. The IHR was first established in 1969. The reason for the revision was a number of different factors. At the time, there were many outbreaks like SARS and avian influenza, and the WHO recognized that border control measures were ineffective, and they saw a need to contain the disease at the source. And pest, cholera, and yellow fever were the diseases that were handled in the 1969 version. And the WHO recognized that they needed to expand that to include all acute public health events. And they also realized the need for real-time response with contact points in each member country. So since 2005, the IHR came into force. So they introduced the PHEIC system, the Public Health Emergency of International Concern system. And they had a number of criteria to determine whether something was a fake. For instance, is the public health impact of the event serious? Is there a significant risk for international spread? So if something fulfills all this criteria, it constitutes a public health emergency of international concern. So COVID virus is the sixth fake since the 2005 IHR came into force in 2005. When a disease is declared fake, then the WHO takes a number of different responses. First of all, it coordinates global surveillance and assessments of the health risk. And they also develop and provide recommendations. And there are two types of recommendations, temporary and standing. And the WHO also starts mobilizing resources. And this is how they fight and try to contain the disease. And if you look at the recommended health measures, you can divide into two types. So one that deals with people and the other that deals with baggage, goods, cargo, and containers. You can see that when it comes to personal health measures, this pertains to medical exams, vaccinations, contact tracing, isolation, etc. Whereas when it comes to recommendations related to baggage and goods, they carry out stronger inspections and safe handling, and sometimes they seize and destroy items and goods. So, of course, in an ideal scenario, the member countries will follow all the measures, but that is not the case in reality. The WHO, for instance, is not for the lockdown or closing of borders, but member states, especially in the initial stages of COVID, opted to close their borders. And this led to a lot of chaos and confusion in the initial stages. And many countries felt like they had to protect their citizens, so they closed their borders and tried to wait it out. And what happened is, as a result, is that in many countries, key public health initiatives, for instance, rehabilitation, mental health services, and other key medical services were interrupted. And for instance, in some countries, medical professionals were displaced or traffic was cut off or shut down, and some other medical services were not provided to citizens. And this is when countries came to realize that these lockdown or border control measures were not that effective. And of course, some of this happened in Korea as well. And we saw some changes in Korea. We saw pneumonia and these diseases decrease, and we also saw a decrease in food and waterborne diseases as well. And other respiratory diseases actually declined as well. However, mood disorders, neurosis, and stress-related disorders actually increased in Korea. And as for diseases not associated with COVID-19, we saw that some chronic illnesses may rise in the future in Korea because early detection of some of these diseases have been put off. So we saw that people with existing conditions were treated, but those with newly developed such diseases were not receiving or having the ability to detect their conditions early on. So the second wave occurred in November last year, and it worsened until January and February this year, and then it subsided. So why did this happen? Why did the second wave happen? Many experts are looking at the virus and what sort of changes have happened within the virus. And it is true that there were changes in the virus, and we were not aware of any variants until early January. So here you can see the variants of coronavirus. One from Brazil, one from South Africa, and one in the UK. And how did this impact COVID-19? How will this impact the vaccination that is going on? Many experts are still concerned about these variants and their impact. Will the transmission and severity of COVID change due to these variants? It has been noted that the transmission rate has increased and the severity has also increased as a result of these variants. What is most notable about COVID is that the infected can transmit the disease to others even before the symptoms are shown. And the symptoms actually disappear after about a week of infection. And that is why quarantine and isolation is key to containing this disease. And that is why contact tracing is so important if you take into consideration the natural history of this disease. And if you look at the triage of patients, In China, around 80% of infected had a moderate case. If you look at Korea, 90.9% had moderate cases. This means that 80 to 90% of infected people do not need a special treatment. They do not need oxygen treatment, but the other 10% will go to the ICU and they are more likely to die. And I think that the 2 points that I shared with you now, the transmissibility of the disease before symptoms show and the triage of patients is key in containing this disease. Also, if you look at this slide, you can see that household transmission rates are 6 times higher than non-household contacts. And so these are the 3 key characteristics of this virus, and we need to take this into consideration in coming up with quarantine measures. If you look at the host, there have not been that many changes. Initially, many of the elderly were more at risk for COVID. If you look at the long-term care facilities, in the initial stages, there was a high death rate and a high transmission rate. But as the level of quarantine in those facilities increased, the death rates and the transmission rates dropped. So there has not been that many changes in terms of the host. So what is most important is that given that there is no treatment, we need to be able to contain the transmission of this virus. And when we think about that, we often refer to the reproduction number. So we need to work to reduce the reproduction number. And that is why the government carries out shutdowns. And so the second wave came as a result of easing of social distancing measures and reopening schools. And easing distant working and learning. So in other words, introducing non-pharmaceutical interventions and lifting and strengthening NPIs has a great impact on the reproduction number. And the second wave came as a result of the easing of NPIs. So if you look at the preparedness of each country, with the exception of a few countries, many countries were not prepared for the easing of NPIs. In many countries, there is a surge in infected people. And so in those cases, countries do not have a lot of resources to focus on other areas. For instance, contact tracing and isolation is very, very important. But in many countries, they do not have the resources or the time and energy to focus on these measures. They are already quite overwhelmed with having to treat patients. So the preparedness of each country is not that different from the start of the outbreak. And many countries are now relying heavily on the vaccine. If the countries do not or cannot build a strong infrastructure, they have no option but to rely on the vaccines. There are many lessons learned from countries around the world. First of all, there is a knowledge of infection status, and we need to be able to disseminate that to the public. And this needs to be used to encourage the participation of the citizens. And we also need to be able to manage an increase in patients. That means bolstering the health system of a country. And also, when patients or people who are infected travel abroad, we need to have border control measures. And so what you see here are some of the key measures that were taken by countries around the world. And there are countries who did implement these measures quite well, especially countries in the Asia-Pacific region. But however, there are some countries who were late in adopting these measures, and that led to a surge in COVID cases in those countries. So now I would like to move on to how Korea responded to COVID. And I think that Korea was quite lucky in a sense. And the reason why I think Korea was lucky was it had previous experience with SARS in 2003 and PI in 2009 and MERS in 2015 and 2018. So we were actually prepared. 95% of the medical facilities in Korea are privately owned. And most of these places have screening facilities like PCR. And we had enough medical facilities for quarantine and isolation, and we had enough medical professionals to deal with a situation like this thanks to our previous experience. And I think that especially in the public sector, we had a lot of personnel to carry out contact tracing, and we had an abundant stockpile of PPE. And we also have, for instance, we utilize DUR to trace patients who have been abroad, and we had these technological advantages. And also in public hospitals, we had enough beds and wards, FETPs and EOCs, and we had fever clinics at public health centers. So we had the infrastructure in place, and we were prepared for COVID. And many Koreans were aware that they could actually catch a disease abroad. So there was a general public awareness among the citizens, and information was shared quite swiftly utilizing SNS. So there was a preparedness for imported disease in the Korean society.
Particularly, the reason why Korea was very well responded in terms of COVID-19 has to do with a very strong vertical program that included inoculation as well as immunization. So they had a public health system in place. And second, because we have universal health care by the National Health Insurance System, patients were supported via the government. And the public and private worked together. In other words, there was an amicable public-private mix in place through various programs. And as I've mentioned, rather than utilizing co-payment, it was that the government supported for the treatment for patients. Social insurance, and also the infrastructure of ITC were also some of the advantages that we had in treating this illness. So as I've already mentioned, SARS is a level 4 infectious disease. And in order to manage such diseases, we had 11 nationally designated hospitals, but we expanded that to 19. And we had 2,000 that were able to be accommodated through isolation units. And this is a picture that I took when I was at the KCDC. You can see there are 10 beds, isolation unit that was established at this particular hospital. And the reason why we were good at our response was the following. Jeffrey Sachs, when he was putting together his SDG report, he talked about how early response is critical. So contact tracing and target testing and quarantine, isolation, and early treatment were some of the items that were cited as key in the early response to contain the disease. So that was in his report. And as you can see here, we have those via immigration. So from the airplane, they're managed and controlled. And when necessary, there is isolation, quarantine measures in place. Not only that, if there's a fever through fever screening and applications and PCR testing, we were able to control the flow into Korea. So there was good border control. And not only that, in the communities, there are fever clinics, and also in the district health centers, there are swift screening measures in place. So with regard to screening, contact tracing was also critical. CCTVs and other equipment and facilities were utilized to trace the contact. So they were triaged or classified, and those that had mild symptoms went to mild hospitals. And depending on the severity, some were sent to the hospitals that can deal with severe cases. And not only that, for tracing purposes, we also utilized the QR codes. And you can see that the overall circulation was tracked and traced. And not only that, here, the emergency service unit, through their triage, has been proven very helpful in the process. 80% of natural deaths, or 90% of deaths, you can see, had to do with oxygen. So you can see that the patients were classified, and they were not all sent to these tertiary hospitals. There were hospitals which were actually started off from dormitories. They changed the facilities of the dorms to make this into hospitals so that we can prevent the overflow into tertiary hospitals. So in other words, the medical facilities were systematically managed, and I believe that this was also one of the success factors of Korea's response. And also to deal with critical cases, transfers and designated hospital systems were put in place. In other words, we had a network of hospitals. With the surge of patients, and when we do see a community spread, there are measures that can contain this spread, and those include behavioral changes. That would include wearing masks, washing the hands, cough etiquettes, and frequent ventilation. So in other words, these behavioral changes were quite keen in containing the disease across the community. There was also contact tracing and social distancing that contributed to containing the spread. In other words, it's about closing the workplaces, the schools, and reducing the number of sporting events. And you can see that this can be all brought together and summarized into the acronym BTS. So the BTS countermeasures have enabled us to prevent the community spread. We can also call this as non-pharmaceutical interventions. As I've already mentioned, washing the hand, wearing the mask, these are critical elements. From February, we've put on our face masks and making sure that we have the right coughing protocols. And social distancing is also something to note. We've put together a system for social distancing. For instance, we have level 1, 2, and 3. So originally it started with 3 levels, but we added additional levels of 1.5 and 2.5 to have 5 levels. So in level 3, more than 10 people cannot gather together. In level 2, indoor, only 50 people, and our outdoors, only 100 people can gather. And for level 1, there was a lot of PR and promotion efforts to the public. And for sporting events, for level 3, they're all closed. And as for social services facilities, in level 3, everything's all closed. And at level 1, it can resume. So there were certain criteria and guidelines that were put in place so that we can all adhere to social distancing guidelines. And in order to expand social distancing, the government offered stimulus checks. This was an incentive for the government suppression strategies. We utilized ICT to select eligible people. And not only that, they did not necessarily have to go to bank to cash in the checks. They were able to utilize internet connection to cash in their checks. So the ICT came very handy in this process. In addition, in order to change the behavioral, to induce behavioral changes, there was a lot of convincing, changing or amendments to rules and enforcement. There was education and training involved. There was also exemplar or best practices showcased on TV. And not only that, we changed the environment or the circumstances. In other words, we had a supervisor or a manager on quarantine to make sure that social distancing guidelines are adhered to. So these were some of the behavioral intervention methods that we put in place. And thanks to these efforts, well, finally, you can see that vaccination would be the very last stage, and we were able to come to at this current state. There are about 7 vaccines that can be used to bring up herd immunity. We have Johnson & Johnson, Pfizer, Moderna, and AstraZeneca, and we are trying to bring up the herd limit. By the end of this year, maybe November or so, we're going to have close to 70% of the population vaccinated with these vaccines. But of course, there are some concerns where if we do have a surge of patients, we should not only manage at the hospital level, but we also need to have home care facilities. And also to make sure that there's no transmission within the household, we need protection measures for the aged or the elderly. In other words, we need these community-based approaches that are necessary. And the second is probably one of the most critical part, which is about vaccine research and development. There was a lot of progress. We are currently putting together a monoclonal antibody, and we're currently engaging in vaccine trials. But what's most important here is R&D. R&D is critical in vaccine development. So with regard to R&D, a lot of cooperation will be necessary with various countries around the world. And right now, the most important thing is to respond to variants. It's true that maybe vaccine development up till now would be obsolete due to these variants. As mentioned, we have very swift transmissibility of the disease. Severity may change, and reinfection rates may also go up due to variants, because even if you are inoculated, you might get this infection again. So how should we solve this problem? The countries need to engage in joint efforts and has to engage in vaccination altogether. However, because financial resources are necessary here, it's very difficult to do. We have the rich and poor around the world, and it's important to provide equitable distribution of vaccine, but this is a challenge right now at hand. In 2009, in order to solve this situation or this problem, there were a lot of discussions underway. At the time, there were countries with vaccines and without vaccines, and the latter struggled. So what happened was WHO put together a COVAX facility where many countries would be chipping in or pooling their money to offer vaccines to low-income countries. And this vaccine is a public good. In other words, all countries need to have access to this public good or this vaccine. This is a critical element in this international community. However, for certain vaccines, you can see that certain countries or certain developed nations stockpiled on this vaccine, making it inaccessible for other countries around the world. However, going forward, international collaboration should be all the more strengthened, and WHO may be at the center in this process, or we can also have countries with diverse experience come together to engage in multilateral diplomacy in health, particularly PPE and various techniques, infection control prevention techniques, and ICT and R&D will be some of the elements where cooperation may be possible amongst countries, especially through bilateral cooperation. In Korea, we utilize applications, as I've already mentioned. We've engaged in contact tracing. There were many quarantine tracing methodologies and testing techniques that we've introduced. Various materials were utilized, and for patient care, we had ample experience. Training of workforce was also another example. Surveillance, research, and epidemiological data gathering are some of the areas where we believe Korea can cooperate with other countries. PPE and other medical materials, masks, drugs, vaccines are also other areas where collaboration may be possible. And only with such collaboration can we contain this disease, because once again, it's about these materials being a public good. It's to make sure that equitable distribution of these materials are offered to all countries around the world. And only then can we manage this pandemic. So what's most important at the end of the day is that we're all on the same boat. It's not about a country being at the forefront and that's it. Just to have high vaccination levels in the US will not solve the problem, because we have many entrants into the country. So international collaboration is key. So let me summarize. COVID-19 is about behavioral change, it's about social distancing, and it's also about testing and contact tracing. And basically, it's about BTS, the countermeasures that I've already mentioned. Primary clinics and triage at the hospitals is key. And in order to deal with this pandemic, leadership is also paramount, and transparent public communication should be offered to the citizens if we want to obtain trust, and only then can we solve or overcome this pandemic. We have the aged or the vulnerable group, and we need to protect them. I've mentioned that stimulus check is also necessary for this particular vulnerable group. Global alliance and solidarity should all the more be strengthened in order to jointly tackle this pandemic. And as I've already mentioned, R&D is of course critical. And through R&D efforts, we will have to jointly develop vaccines as well as therapeutics. Countries all have to engage in vaccination together. It has to be a joint effort. But COVAX facilities can help developing nations and underdeveloped nations. We need to support them as well. And only then can we manage and tackle this pandemic. And a key characteristic of this pandemic or COVID-19 will be the variants. As you can see that the flu and a variant of the flu has led to this pandemic. It's a national selection process. And here as well, collaboration is important. We need to monitor, we need to engage in surveillance and respond accordingly. And with that, let me conclude my presentation. But last but not least, I want to say that COVID-19 pandemic will not be the last. Well, who said this? The Director General of WHO, Dr. Lee, that was on the post till 2004. And on his tombstone, it says, "We will move forward towards the goal of health for all together. Learning from the past, we can change the future of global public health." This was by the late Lee Jong-wook, Director General of WHO till 2004. So it's about learning from the past and being in this together, being this a joint effort. So this is on his tombstone. So I wanted to mention this because this is a very important concept in managing and responding to this pandemic. So with that, let me conclude my presentation. Thank you very much for your attention.
Thank you very much, Dr. Lee, for your presentation. He talked about how past experiences are key in solving problems or issues of today. So I believe that our experience that we are building today will become key in solving potential problems in the future. And I hope that this seminar today will contribute in accumulating necessary experience. Next, we would like to invite Dr. Nina Monrad-Boel. She is currently the health counselor at the Embassy of Denmark in Korea. She was also an executive at Amnesty International. Without further ado, I would like to invite her to the podium for her presentation.
Thank you very much. 감사합니다. So my name is Nina Boel, and I'm a medical doctor working at the Danish Embassy. And I think there's a bit of echo. Okay. My role here at the Embassy is to support the government-to-government collaboration on health between Denmark and Korea. Thank you. Okay, so this is just to give you an idea of Denmark. For those of you who are not familiar with the country, it's a rather small country in Northern Europe. It's approximately half the size of Korea, and in terms of population, we're about 1/10. Denmark and Korea face some of the same challenges in terms of demographic changes. We both have aging population and, of course, more chronic diseases. And in terms of COVID-19, this is, of course, a challenge when we see a pandemic that hits the elderly part of the population unproportionately hard. In our country, in terms of the healthcare system, we have 3 levels. We have the overall policy setting from our national level. Then we have 5 regions that administer our general practitioners as well as our hospitals. By far the largest part of our hospitals are public hospitals. And then we have 98 municipalities, and at the local level we have interventions in terms of prevention, rehabilitation, and care for our senior citizens. In terms of our state's response to the COVID-19 pandemic, the Danish approach has been to approach and control COVID-19 in a systematic way, to act timely and decisive. The aim is to ensure that the spread of COVID-19 is limited within the available healthcare capacity in our country. And we've taken action both at national and local levels, depending on the specific situation of the outbreak. The first lockdown was in February 2020, where people were advised to stay home and not see family nor friends. And at that point, in terms of our senior citizens, we had a complete lockdown of our elder homes. Since then, we've been seeing the numbers going up and down, and currently Denmark is in the middle of a cautious reopening of society from the comprehensive lockdown that was initiated in December 2020. The reopening of our society is highly dependent on the COVID-19 passport, a certificate that states whether citizens is either vaccinated, has recently recovered from COVID-19, or can present a negative COVID-19 test. So the Danish effort to reopen society goes hand in hand with increased testing, and currently our capacity is approximately 400,000 COVID-19 tests per day, and that is 200,000 antigen tests and 200,000 PCR tests. And PCR testing, of course, remains our most reliable tool and also allows our genome sequencing. So Denmark is right now screening 90% of all positive PCR tests. And at the same time, the rapid antigen tests and the self-testing are becoming increasingly important as part of the Danish test strategy. Before I talk a little bit more about the regions and the pressure on them, I would mention as of April 13, the following has been applicable for both our regions and municipality with a low incidence of COVID-19. So first of all, right now our students in primary schools, secondary schools, and some adult education programs have returned fully or partially. Stores, smaller malls, and arcades with a size of no more than 15,000 square meters are open. Outdoor cultural facilities and liberal service professions, such as hairdressers and others, were allowed to reopen on April 6, when visiting customers have this, what I mentioned, the COVID-19 passport. Furthermore, reopening is planned in the coming month. Through the plans, of course, conditioned on the continued control and spread of the disease. So the following restrictions are still in place. We have a recommendation of maximum of people who can gather in private homes and meet in the social bubbles, we call them, of 5 people, and of course the recommended distance of 2 meters. Outdoors, this is for indoors. Outdoors, we have a maximum of 10 people. We also have a ban on indoor and outdoor on-site consumption of food and drinks at restaurants, and that is planned to open later in April 21st for outdoor and in May 6th for indoor. Also, in terms of cultural and sports facilities, they stay closed. but we hope to open for children under the age of 18, 21st of April, and adults on May 6th. So this is the reopening plan in phases. So as for the reopening, for the regions, they are responsible for our primary care in terms of our general practitioners, and then also for our hospitals. So of course they have seen a very big pressure on them during this pandemic, and through the state we've secured them extra financing, and that also goes to the delay of the procedures that we had planned but have been postponed due to COVID-19. In terms of our municipalities, they are very much in charge of the prevention side, and also information sharing and creating more awareness in society, and this is especially also goes for the vulnerable groups. The municipalities are also in charge of the containment of local outbreaks, and that of course is always with the advice and the support from our health authorities. So in terms of the healthcare system and COVID-19, I would like to highlight that it's we have a tax-funded healthcare system with no co-payment for the patients. So we don't have any patients who've been brought into financial trouble due to treatment for COVID-19. As I also mentioned before, we have the increased test capacity, and I will come back to that a little bit later. Sorry, it seems there's a little bit missing on this slide. I apologize for that. But what I want to tell you with this slide is that we have our general practitioners play a very central part in our healthcare system. So they serve as a gatekeeper to secondary care, but also as a first point of contact that is actually able to treat a lot of conditions in their clinics. And in terms of the COVID-19 pandemic, they have been in charge of handling the mild cases, and some of them by phone consultations, and also in charge of sparing the hospitals for this overload if everyone was to contact hospitals. And I will also return to this briefly. So we have as I mentioned, a state-run healthcare system, and that also means that it's been possible for us to transfer staff and equipment between hospitals and between different parts of the country when that was needed during the pandemic. I would also like to mention that we have a very well-connected healthcare system, so it's available to share an individual's healthcare data, and that also means that it's been available to all relevant healthcare professionals in terms of COVID-19 treatments. Sorry, this is... I'm sorry, I'm just having a little bit trouble with changing. Okay, now it came. Sorry about that. Changing the slide. Okay, here it is. Sorry about that. So, as I mentioned, the general practitioner playing a very important role in the healthcare system. We have, just to give you the picture, we have about 3,000 general practitioners compared to 18,000 approximately hospital doctors. On an average, a general practitioner has 1,600 patients connected to their clinic, and that's patients that they follow closely and have like the whole history of, and every time they see specialists, the GP will be the focal point to follow up. GPs have a total of 30 million contacts per year, and of those 30% are as phone contacts and 70% are as face-to-face contacts. But having the COVID-19 pandemic, we advised patients to seek advice from the general practitioners primarily by phone, so telecommunications, and we've really seen this telemedicine taking off during COVID-19. As I mentioned, the GP is a gatekeeper to more specialized treatment. Of course, there is, as you can see on this figure, a direct route to emergency care and also to dentist care. But during COVID-19, we've also made a direct route to COVID-19 testing. So the patients can, or anyone in the society can go directly to take a test. They can just book a test and get that for free. As per April 9, we have had more than 23.7 million tests being completed during the pandemic. So we've really scaled this up, and this is of course compared to a country with just about a little bit above 5 million people. So many people have been tested several times. And there has been a total of 236,346 COVID-19 cases, and that is per April 9. And we have seen a death rate of 1%. As of, I have a little bit more updated number from April 12, we had seen 15.1% of the Danish population that has initiated the vaccination program, while 7.7% are fully vaccinated. And when we get to receive larger amounts of vaccines, we'll be able to vaccinate 100,000 citizens a day, and that's just below 2% of our population in just one day, if we have enough vaccines available. And we have just recently adjusted our vaccination program slightly from what I had in this slide, since we halted the use of AstraZeneca vaccine. So since that is out of the question now, then we had to delay our vaccination schedule. And that means that we are now aiming to have everyone vaccinated by the end of August. And this is just to show you the hospitalizations according to date, to show you a little bit of the waves that we've seen in Denmark. And you can see it was quite heavy around Christmas. This is also to show you the distribution in Denmark according to age. And as you can see, we have luckily been able to protect the senior citizens quite well. So primarily it's amongst the younger part of the population that we see the cases. I will now turn to some of the digital initiatives that I understand is what's also interesting for this conference. So one initiative is the COVID meter, we call it. So the Danish health authorities, they have introduced a digital initiative to measure the spread of COVID-19. And the COVID meter is an online platform where the health authorities encourage the Danish citizens to register voluntarily and anonymously with their age, gender, and postal code. And when you've registered on this platform, you would be asked once a week to answer questions about whether you've been feeling sick, if you've been tested for COVID-19, if you've been in contact with any friends or family members tested positive for COVID-19, or if you have received the vaccination for COVID-19. So the purpose of this is to give the health authorities some information about the development of COVID-19. And this primarily goes for these mild cases that rarely seek a doctor and maybe don't even get tested. Furthermore, some digital initiatives. As mentioned, instead of having to show up physically at the doctor's practice, all patients have been offered online consultations with their general practitioners. And we have this, as I also mentioned, the general digital infrastructure, which we call Sundhed.dk, that means health.dk. And that is a platform where we can access the patient's information across the country. The patient always has access to all their healthcare data. And when admitted to hospital, they will have access as well. And the GP, of course, also has the access. On the mental side of it, mental health, which was also mentioned previously, As COVID-19 has been a challenge for the mental health of many individuals, several initiatives have been introduced in Denmark to improve this. And one of these is the Red Cross that have been offering digital visits. That's for people who've been reporting to be lonely, and other organizations have also been offering a phone service called the Phone Friends. And that is specifically also targeted our senior population, because as I mentioned, we had the complete lockdown of our elder care homes, and this has of course been very harsh on their side. Another digital initiatives includes the contact tracing apps, which leads me to a number of digital initiatives coordinated with the European Union. So contact tracing, and that's also, of course, what Professor Lee was talking about before. National contact tracing and warning apps are being used both in European level and also implemented nationally, and that's of course also to know if the users have been in the proximity of a person who's tested positive for COVID-19. So through Bluetooth, this app, which in Denmark is called Smittestop, it's what's on this slide, it will be able to register any contact persons who also have the app installed on their phone within 1 to 2 meters of distance. And in the case of an alert, the app may provide relevant information from health authorities, such as advice to get tested or to self-isolate, and who to contact. This app can be installed voluntarily if you're 15 years or above, and they are working across the borders of the European Union, so it makes it safer to travel within the European countries. The data is collected anonymously, and it is not possible to transfer the identity of the users of these apps. And the aim is, of course, to visualize patterns of contact and thereby supporting government decisions about the gradually opening of societies after the pandemic. So I will now just see if I can play a video for you. Is it possible? I press one more time? No? So that was just to show you the video of the contact tracing app. As for artificial intelligence, the analytical power of artificial intelligence and high-performance computing are major assets when it comes to detecting patterns and the spread of COVID-19. With their help, public health sectors can monitor the spread of COVID-19 and quickly devise effective response strategies. In the healthcare industry, artificial intelligence also plays a part in powering the robots and other tools when coming into contact with patients, as human interaction should of course be kept to a minimum. And furthermore, another example also from the European level, European supercomputers. We have three powerful European supercomputer centers that are engaged in studying and developing vaccines, treatments, and diagnosis for COVID-19. And these supercomputers, they examine which combinations of active molecules react to the virus by comparing digital models of COVID-19 proteins and then matching them against a database of thousands of existing drugs. So in this way, the supercomputers complement the classical trial and error of the clinical approach. A pharmaceutical company and several large biological and biochemical institutes participate by providing access to their databases of drugs. And data from space, another example, the EU space program offers free and open data that helps to monitor and potentially mitigate the impact of the COVID-19 outbreak. So this is done through its Earth observation component, Copernicus, and its satellite navigation system, Galileo, which is using more than 30 satellites. And since the beginning of the COVID-19 crisis, the EU satellites have been monitoring traffic congestion at border crossing between the EU member states and mapping medical facilities, hospitals, and other critical infrastructure. So this provides public authorities at EU and national levels with models to better understand and tackle the emergency. And in terms of this data from space, on 5th of June, the European Commission launched the Rapid Action Coronavirus Earth Observation in collaboration with the European Space Agency. The Rapid Action tool relies on satellite data to measure the impact of COVID-19 lockdown and monitor post-lockdown recovery at local, regional, and global levels. The data is then analyzed using new digital tools such as artificial intelligence. And I will also just show you a video of that. In terms of networks and connectivity, EU member states have introduced social distancing measures to fight COVID-19. So, of course, as you all know, the demand for internet connectivity has increased dramatically. For instance, for teleworking, e-learning, entertainment, conferences, as we're having today. And this is straining networks in European countries. So to prevent network congestion, the EU has encouraged that streaming platforms offer standard rather than high-definition content, that telecom operators take mitigating measures to allow for continued traffic, and thirdly, that users apply settings that reduce data consumption, including the use of Wi-Fi. And the EU has set up a special reporting mechanism monitoring the internet traffic situation in EU member states to be able to respond to capacity issues. Also in terms of fighting disinformation, which I know you also have very important and a lot of focus on in Korea. Disinformation is spreading rapidly online and particularly on social media. At times, disinformation about COVID-19 can lead to serious harm or health risks. So in collaboration with in the EU with Google, Facebook, Twitter, and Microsoft, there's been an agreement to actively promote authoritative sources, demote false or misleading content, and launch new tools that lead users directly to authoritative sources of information or provide accurate multilingual information on the COVID-19 crisis. And some examples of this include Google search giving prominence to articles published by EU fact-checking organizations, Facebook and Instagram directing over 2 billion people globally to resources from WHO and other health authorities. And Twitter's COVID-19 curated pages bringing together the latest tweets from a number of authoritative and trustworthy government, media and civil society sources in local languages. And YouTube displaying information panels linking to health officials on its homepage and in panels that appear on videos and searches about COVID-19, reaching more than 300 billion impressions around the world. The platforms has also been removing illegal content and COVID-19 disinformation. And the EU has set up a program to monitor the actions that platforms are taking to limit the spread of COVID-19 disinformation. And of course, this also applies to our children, a focus on staying safe online. But due to the heightened online activity of our children and schools being closed and lectures being online, that has increased the risk of the vulnerability of our children when they are online. So the EU has developed this online safety advice for parents and carers in the collaboration with international partners, and the aim is to keep children safe online during the COVID-19 pandemic. Furthermore, the EU is focusing on online scams related to products that allegedly can cure or prevent COVID-19 infections. And the EU Commission is working with online platforms such as Amazon, eBay, Facebook, and Google to discuss new trends and business practices linked to the pandemic. As a result, the online platforms have reported the removal of hundreds of millions of illegal offers and advertisements and confirmed a steady decline in new COVID-19 related listings. So in terms of the life after the pandemic, social distancing has transformed the way we connect, research, and innovate at work. To help employers, recruiters, and educators ensure that Europeans are equipped with digital skills in the post-COVID-19 context, EU has launched a new digital competence guidelines that include practical steps, key actions, tips, and online resources for digital users. These will help citizens make the best use of their digital competences from the perspective of the employability path, from education to sustainable employment and entrepreneurship. And in terms of the digital vaccination certificate that I also mentioned previously, in terms of the post-pandemic preparations in Denmark, we have introduced this COVID-19 certificate, and it will be an app that can be downloaded by all Danish citizens, and it will show test results, personal vaccination status, and it will be able to indicate whether you've been tested earlier on. The purpose of this app is to contribute to a safer reopening of the society in Denmark. Many EU countries have discussed introducing digital vaccination certificates, which would potentially make traveling around the European Union, especially for business trips, more easy. However, there are of course still pros and cons of these certificates, which are being discussed. So this marks the end of my presentation. I thank you for your attention. Thank you very much.
Yes, Dr. Nina Monrad-Boyle, thank you very much for your presentation. You've mentioned about a network-based collaboration and cooperation, and technical assistance and also cooperation for that end was emphasized. And she also mentioned about in order to respond to crisis, to utilize ICT as well as digital technologies, as well as the necessity of policy support was the gist of her presentation. And I truly hope that the seminar contributes to that endeavor. Thank you very much once again, Dr. Boyle, for your presentation. We will now move on to the last presentation of this session. The next speaker is Norliza Binti Nordin, American Deputy Director of the Ministry of Health of Malaysia. She has provided us with a video for her presentation because she is in Malaysia right now. So let us now listen to her presentation.
Very good afternoon to all. Thank you to Korea Local International Research and Development Institute for inviting us to share our experience in managing COVID-19 in Malaysia. I shall give a brief on the current COVID-19 situation in Malaysia and what are the challenges and lessons that Ministry of Health faced managing COVID-19 for almost 1 year. As still 13th April 2021, the total COVID-19 positive cases was almost 364,000. On the 25th January 2020, the first case of COVID-19 was detected in Malaysia and traced back to 3 Chinese nationals who previously had close contact with the infected person in Singapore. Since then, Malaysia has experienced 3 waves of COVID-19 cases, and if lack of adherence to the standard operating procedures, we will be expecting the 4th wave soon. This summarizes the challenges and lessons learned in managing pandemic COVID-19. Leadership and teamwork were the important elements throughout the response of COVID-19. The pandemic of COVID-19 has demonstrated that good leadership and good planning at different levels are crucial. Factors that can leverage on having some foresight, even during such challenging times, includes previous experience on pandemic management and rapid synthesis of current evidence, which facilitates quick response to arising issues. Ability to predict the future based on data will add value for projection of health facility preparedness to the pandemic. Coordination across and between multiple levels from central to state to district, from primary care to hospital was essential in the implementation of strategies that were planned. This mechanism of command is from National Security Council, chaired by the Prime Minister himself. The various ministries are involved in prevention and controlling COVID-19 at various agencies throughout states and districts. Ministry of Health played a crucial role in the prevention, controlling, and treatment of the COVID-19. The Director General of Ministry of Health is the chairman of the technical committee. Human resource is a crucial element in managing in the pandemic. Human resource mobilization within the Ministry of Health was an important strategy to increase human resource capacity during a pandemic, enabling personnel to be modified to tasks of priority. In addition, recruiting other available human resources, which are such as retired personnel, new graduates, academia, and other volunteers, was also an effective strategy. For the healthcare sector, personnel involved have the competency in carrying out the tasks required. Nevertheless, the process of screening volunteers was rather time-consuming, and the lack of centralized database for volunteers meant that recruitment has to be started from scratch. Nevertheless, experience from pandemic has highlighted the importance of ready-to-serve workforce in terms of volunteers, whereby by there are identified individuals who are keen to participate in the future activities. Challenges were also faced in terms of skill and competency of the healthcare workers. During the early phase of the pandemic, and with COVID-19 being a novel disease, healthcare workers may not have been fully aware or familiar with the clinical guidelines on the management of COVID-19. Restriction of movement also impeded training sessions, which are usually conducted face-to-face. Despite restrictions were eased, the number of participants were limited. Nevertheless, adopting innovative approaches, sessions were converted into online engagements through webinar sessions or development of education materials which could be shared across the social media. For example, with the continuous evolving evidence of COVID-19, the Infection Control Unit has to ensure these updates are relayed and made accessible to healthcare workers. Therefore, slide presentation tutorials, pamphlets, infographics, and video containing information on infectious preventive control are produced and distributed to all healthcare facilities. In addition, healthcare workers themselves were at constant risk of exposure to the virus. And this risk is compounded by the risk of psychological effects such as anxiety and depression due to stigma. In the very early phase, there are also some concern among healthcare workers regarding fear of contracting the infection from patients. A system of continuous guidance and close supervision as well as monitoring within the occupational health and safety team within the healthcare facility, which give feedback to the national level, were important to monitor the well-being of all healthcare workers and establish a mental health and psychosocial support platform were also paramount in ensuring the sustaining the motivation and drive for healthcare workers to perform their duties. After realization that costs during the pandemic is related to the preparedness of all healthcare workers to work in a crisis setting, COVID-19 challenged the healthcare system to such an extent that all personnel, from technical to support, from clinical to non-clinical, were involved in some way in the country response. Hence, the coining of terms such as frontliners and backliners. Tasks were conducted with many other agencies, both governmental and non-governmental, highlights an all-out response in a huge team. Hence, it's important for all personnel to have some form of training or preparation in public health emergency setting and working in tandem with many partners. These preparations are not only physical but also mental. Ultimately, the ability to anticipate possible related to healthcare workers during pandemic crisis will add value in ensuring more effective and efficient management. Indeed, the whole experience had taught an invaluable lesson of teamwork and coordination. The different strengths of respective personnel in the various teams harmoniously complement each other, creating dynamic teams that were able to respond potentially as the pandemic situation evolved in the country. Communication spanned across multiple levels and settings, enhancing various collaborations and cooperation. Good coordination at the ministry, state, and facility level is another critical element to ensure smooth flow in the process. Transparent communication across multiple levels is crucial to obtain trust and confidence, hence facilitating data collection, solving conflicts, disseminating of accurate information and policy, as well as peer learning. Furthermore, in times of scarcity, arose opportunities to strengthen partnerships with non-Ministry of Health and private healthcare sectors in sharing resources to increase hospital capacity and maintaining essential hospital services, while Ministry of Health facilities take on the role of treating COVID-19 patients. Another hurdle that needs swift addressing is the spread of false and fake information news throughout social media, which trigger panic among not only the healthcare workers but also at all levels. False news was disseminated among the public as well, prompting risk of misinformation and misinterpretation. This would increase the anxiety and fear in asserting which was already full of uncertainty and anxiety. Designated teams were tasked to address such fake news, providing the public a means to access verified information. Given such extreme circumstances, comprehensive data sharing and management of the COVID-19 pandemic information are crucial. The pandemic has also shown that the ability to collect and analyze data effectively is very important to ensure and quality data are obtained. Obtaining complete, accurate, and prompt data daily is a massive challenge for personnel working within the data management terms, which were simultaneously collecting various information from health facilities, district health office, and state health office for further analysis at the national level. Challenges were many, such as frequent follow-up needed to ensure completeness of the data, and in many facilities, data management and the listing were done manually, including epidemiology curves for monitoring of disease at district health office. Due to the high effectivity, case investigators were done mainly through phone calls. In certain rural areas where there are poor phone and internet coverage, case investigations requires home visits and precautions has to be taken to the facilities involved in communication. The data management team in charge of all hospitals, for example, also face a challenge in gaining trust from hospitals and clinicians to disclose detailed clinical findings. Therefore, frequent engagement and discussion of visibility issues between data managers and infectious disease team which able to build a good rapport between the team and infectious disease services and help to overcome the situation as better understanding with hospitals and clinicians developed nevertheless. The process of data verification before performing analysis was indeed challenging and indeed especially in dealing with thousands of patient clinical data in case of COVID-19 pandemic in Malaysia, despite not being in direct contact with the patient of COVID-19. Data management team's findings will be shared with the public during the regular press conference. However, experience in handling large amount of patient data in the system that still depends on manual entry or information was valuable. The whole process highlights that the importance of accurate and reliable data integrity. The challenges the health sector faces in responding to unprecedented public health emergency is also highlighted. The importance of quality data collection and application into decision making is valuable. The role of data managers and analysts in day-to-day operation of a health system is significantly at this time invested. As the amount of medical equipment increases tremendously during COVID-19 due to prevention, controlling and treatment of COVID-19 cases, procurement has to be made rapidly and parallel to the needs. Engagement with Ministry of Finance were commenced and the process was fast-tracked. As the number of cases increased, the resources in the Ministry of Health was stretched and the private agencies' engagement was crucial. Various non-governmental agencies and private sectors gave contributions in terms of services and other means. When this pandemic waves in, the delivery of services has to evolve according to the change and need much improvement. The infectious control measures has increased with evidence of designated infectious area in health facilities are mandatory, and the special needs to specific services need to be considered and replenished. Changes in working environment and processes significant during the COVID-19 pandemic. With the movement restriction and need for infection prevention and control, organization management had to adapt to changes. For instance, within the Ministry of Health, several initiatives were taken by the management program with the aim of ensuring that response activities could be implemented smoothly in the field and ensuring good quality health services could be delivered efficiently despite the highly demanded requirement of COVID-19. One of the significant change was enabling personnel to work from home with circulars and guidelines produced. The guidelines provided explanation on the roles of departments working from home and shift rotation system were relevant. Moreover, modifications in the work process were implemented to ensure personnel comply to the social distancing policy upon returning to work in the office. Deferment of non-urgent meetings and conducting urgent meetings through online conference will also done in order to reduce risk of transmission of COVID-19 among the staff. And recruitment of healthcare workers to address needs of the COVID-19 activities were facilitated by coordinated and streamlined work process formal letters. Engagement of healthcare workers of various healthcare workers in different disciplines were conducted in a swift and timely manner and ensure officers who report duty as soon as possible to participate in response activities. This will reduce the burden faced by other healthcare workers. As I mentioned previously, several healthcare workers were recruited on contract basis such as nurses and paramedics. Circulars were also prepared to facilitate the allocation of COVID-19 special allowance. And in terms of training, such as training institutes, improvised meetings and learning materials were provided online. The teaching staff and trainees were also deployed to assist in the frontline gaining experience learning in managing pandemic. This COVID-19 pandemic provided stimulus for many initiatives leveraging on digital health. However, several issues were noted, including infrastructure and the healthcare worker competencies similar to many other government agencies. Limited infrastructures to support online transaction was the main challenge that they had to be overcome. Infrastructure limitations such as lack of video conference hardware, software, and inadequate bandwidth were among the glaring issues recognized in the rural area video conferencing session, which will conduct during COVID-19 period, were frequently hampered by unstable internet connection, and some equipments were almost obsolete and clear message may lead to miss. Undocked. Apps and system also pose its own limitations. For example, ensuring system security is important to keep data safe from hackers and data leak. However, infrastructure of the system would require a high-end server to host the current system. This implicates on the cost for future maintenance and upgrades of the system, which have different standards used by the existing system, present a challenge for Ministry of Health. The advantage of data gathered using digital means are numerous to begin with. Data obtained is less liable. Recording errors, which could occur when information is transferred from paper from digital recording, overcomes eligible handwritings discrepancy and the labor burden associated with manual processing procedure. And real-time data processing can enhance the efficiency of outbreak management at all levels, and this can be done by strengthening digital health capacity, moving towards steps to equip Ministry of Health facilities with prompt and educate its support infrastructure in a relevant priority. Another issue and challenges pertaining to COVID-19 pandemic was an unprecedented high demands for COVID-19 treatment. Few strategies implemented such as close communication and discussion with the infectious disease specialists to identify the list of drugs that are currently used in combating COVID-19 disease were then procured centrally through emergency procurement procedures with special price negotiations with the distributor and manufacturer. The medicine that are urgently needed during COVID-19 pandemic, and approximately about 60 million was spent to purchase this product. In addition, there was interruptions in logistics of medical supply during pandemic due to the Movement Control Order or MCO by Malaysian government as well as locked in other countries. Discussion and collaboration with Ministry of International Trade and Industry were engaged to get approval for pharmaceutical manufacturers and related companies to operate during MCO. Meanwhile, the government-to-government engagement was also facilitated by other countries through the Policy and International Relations Division. Ministry of Health Communication has been carried out with Japan, India, China to allow the exportation of pharmaceutical products as well as its active ingredients. There were also high demand in personal protective equipment and hand sanitizer during the COVID-19 pandemic worldwide. PPE, including hand sanitizer, were identified as critical items during pandemic time. This shortage problem was further worsened by the difficulties in acquiring in certain states and district level due to the lack of available supplier during COVID-19 pandemic and difficult to deliver during the MCO period. Besides that, special assessment was needed to ensure the quality of this PPE in order to minimize the risk of infection to the healthcare, and the stock of this PPE with the help of the police force logistic deliveries were able to be carried out smoothly. Stringent procedures criteria was also enforced to the personal protective equipment to fulfill the Ministry of Health product specification. Other than that, there were stock centers for PPE was established, comprising 26 facilities, and close monitoring of these PPE supply done on daily basis in 263 Ministry of Health facilities. Compounding hand sanitizer in-house was done by the pharmacy unit, adopting to the alcohol sanitizer formulation from WHO as a temporary measure to tackle the scarcity. And therefore, medicine and medical supplies, top management and monitoring is crucial to ensure there was a sufficient stock during COVID-19 pandemic. What is the perspective of the community? Ultimately, the pandemic has shown the empowerment of the people to share the responsibilities in responding to the pandemic. In a multi-ethnic and multicultural nation like Malaysia, a common thread connected to all citizens in motivating participation in activities from merely staying at home and fully adhere to the standard operating procedure and to voluntary work in helping. It was also learned that the incorporating the perspective of people was an essential strategy to understand the current issues. The sentiment analysis of the community was one of the approaches in understanding the perspective of the community at large. As the pandemic progressed and response activities continue, the hints of behavior change will be observed in the community, such as adoption of the new norms. However, as the nation moves into recovery phase, sustainability of the efforts is a concern, as there is a concern that the motivation of the public will also wane with time. Realizing that the most important role lies within the Malaysian people, we regard all Malaysians as frontliners, taking care of each other by adhering to the new norms. Thank you for listening.
Thank you very much. You talked about cooperation and communication and the need for a system that allows for cooperation and communication. And she also highlighted how this is a pandemic and how we are all on the same boat. Once again, I would like to thank you for your presentation. And with that, we would like to conclude the first session of the seminar. We will take a short 10-minute break. And after which we will ensue with the second session. We will see you in a moment. Thank you. We had a short break and we will now begin the second session. In this second session, we received questions in advance and we got quite a lot of questions. And of course, we would like to entertain all of your questions, but due to time constraints, we will select a few and ask the questions to our panelists. Before we put forth the questions asked by our participants, I would like to pose a couple of general questions, and I believe that some of these questions might answer some of the questions that have been posed. So this is a question for all the panelists. With regards to your presentation, all the presenters talked about digital technology and information and data. Since COVID, we have seen a rise in telemedicine and the sharing of medical data and personal information, and there have been concerns related to this. Currently, there are a lot of regulations related to this information. Many countries now have regulations in place regarding telemedicine and medical data. So we would like to talk about the easing or possible concerns regarding medical data and also patient data and telemedicine. So if you can share the direction forward, what are some of the controversies and what are some of the issues?
I did present with a couple of slides on this very point. But we have the treatment centers, COVID treatment centers, where telemedicine was already used there. And for chronic patients, diagnosis was done via the phone. And this scheme was introduced and it's already up and running right now. In the future, COVID-19 in our everyday life will be facilitating telemedicine. This is a given, and for deregulation to make this possible, I know that negotiations are currently underway with the National Assembly as well as those in the sector. So it's about convenience for the public, but in addition to that, it's also about autonomy given to the doctors and their diagnosis as well as privacy issues. So it's important to strike the right balance amongst these factors and deregulate accordingly. I believe that this is a key point.
Thank you very much. Thank you very much. I would like to invite Dr. Boll to offer her thoughts on the question.
Thank you very much. So this is a quite broad question and is something that I was also talking a bit in several different slides in my presentation. So first of all, in terms of privacy, as I mentioned, we have the COVID-19 tracking app. We have them at national level, and as I mentioned, they also monitor across borders, so they can be used at a European level for travel as well. But these apps, they are voluntarily, so it's up to the citizens to actually download this app and to participate in this tracing. Furthermore, it's done anonymously, so no personal and private data will be shared within the app. And of course, this is, so it's not as comprehensive as we might see in other countries, because of course you need two people who have both downloaded the app and who are in contact, and one of them would be tested positive and submitting that information, and then the second person would be notified. So you need that to happen before you can actually use it for tracing. And we, so of course it's not as comprehensive in other countries where it is used at large scale. And also the other point in that is that that of course, so privacy issues we take very importantly, But the other part of it is we also want to trust the engagement of our citizens on this. So we also have quite a bit of counseling when someone is tested positive. We ask them to contact their near contacts and on a voluntary basis inform them about the situation. So I think we depend a lot on the citizens' contribution to this. Also on the issue of sharing health data, our healthcare system is very interconnected. So we have we have digital platforms, of course, that connect all our hospitals, that share information across. So if patients are transferred between different hospitals, that information is easily shared amongst health professionals. Then we have this health.dk platform where we upload all the health data information, and that can be accessed by the patients as well as their general practitioners. And if they consent to it, it can also be accessed at a hospital level. We have different types of checks and balances in that system because, of course, it's accessible by health professionals, by doctors. But of course, we have many doctors in the country, and we need to ensure that it's not misused, this access. So one of the security measures is that if we have a doctor who accesses the patient's health data information, and that a doctor is not currently allocated to have a treatment responsibility to the patient, then through the system, the patient would be notified automatically and have an alert in their, we call it the e-box system, which is an electronic platform of communication between the authorities and the people on many different areas. So this is just an example from the health system, would then give the notification to the person that this doctor has accessed your information. Is that correct? So if the patient feels it's not correct, it's easy to submit this as a complaint, and of course it's illegal for doctors to access the health data information without actually a reason to do that. So, but our country is very well connected when it comes to the flow of health data information for the patients. Lastly, I think in terms of the telemedicine, I would just mention that we've seen that there is a huge potential in this because of the COVID-19 situation. We've seen very vulnerable groups in our society who needed to be checked for their health conditions, and we've needed to upscale the telemedicine and the opportunities to receive consultations from doctors through phones, to also be able to continuously enable these vulnerable groups to receive healthcare professionals' advice and also prescriptions of medicines and the like. So of course there are also issues on this that need to be considered, for example, for new conditions, and of course you cannot examine the patients over the phone and these things. But I think we do see there also is a huge potential in actually protecting the patients to them to go to hospitals or go to GPs. Yeah. Yes. Thank you.
Thank you. 네, 감사합니다.
Thank you very much. Next, I would like to ask Dr. Norlisa American for her comments on this question.
Thank you for the questions. This is regarding the telemedicine and digital health in our system in Malaysia. We know that COVID-19 management usage for digital health is very crucial. As I mentioned in my previous presentation just now, that actually we need to disseminate the information fast and reliable. So therefore, although Malaysia is currently do not have the coverage of internet throughout, we have areas that do not have internet coverage. But as this COVID-19 emerged, we see that digital health is very important, and it has expedited the usage of internet and also the usage of coverage towards the areas that we are not covering. And regarding the issues of what is the digital health is having, firstly is the personal health data privacy. However, luckily in Malaysia, we actually have a data privacy law, which is a Personal Data Protection Act, which actually hold on and regards the processing of any personal data. So we have the legislation there. Therefore, there's not much of an issue regarding the leakage of the data. And also during this COVID emergence, we realized that we need to have a system that accumulate all the data of COVID-19 cases and the surveillance that we are doing. Therefore, Malaysia has actually developed a sort of a platform, we call it as e-COVID, in which all the data of any cases will be input into the system, and therefore we can analyze and we can identify the hotspots of where the cases are. And it has been a very good system, and so far we are using it. We hope that in our future, we actually would actually increase our coverage for our internet usage, and also through our system to the district and also the rural areas. In terms of telemedicine, we do have that telemedicine, and during this COVID-19, we see that we are having new norms in which patients are actually given appointments for them to come in, and walk-ins are not actually welcomed in terms of only for emergencies. And if they are, because of this having appointments, there are also we explore a virtual clinic concept in which patient actually can able to consult their doctors from home, and this have been has shows a very satisfactory input from our clients. And there is some of the what you call as initiatives that we do to curb the COVID-19 emergence in our country. Thank you.
네, 답변 감사드립니다.
Thank you very much for your response. Now, I would like to ask some of the questions that were posed in advance, as well as some of the questions that came on while the presenters were delivering their presentations. We have a lot of public servant participants in our audience, and we have a lot of questions for Dr. Lee. And I believe that the question I'm going to ask will be for Dr. Bol and Dr. American. They have asked, do you believe that COVID-19 will be overcome? Dr. Lee, you have many other questions, so this question is for our two foreign speakers. Are the vaccines 100% effective? There are vaccines now. Do you think that the vaccines will be able to protect the citizens 100%? And if not, how effective do you think the vaccines will be?
That is a very good question, a very interesting question. Also a very difficult question, I think, for me to answer. I certainly do hope that we will soon see an end to this pandemic. I think that vaccines play. I think I need to answer this question from a personal point. But in my view, I see the vaccines playing an important part. I completely agree with what Dr. Lee was saying before on that the fact that we need to ensure equal access to vaccines across the world. We see these new variants coming, more mutations. I think as long as we do not keep everyone safe, no one will be safe. And I think that that this is one of the main challenges we have right now, that we are rolling out the vaccines globally too slow, that we do not have everyone on board. And I think as long as we don't do that, I think the virus will keep on having the opportunity to mutate, and that will, of course, affect every society across the world. So in terms of your question on whether the vaccines are going to be fully effective, I would hope, but I think I need to keep that to a hope, because it's very difficult to say with the new mutations and variants coming along.
네, 감사합니다. 답변 감사합니다.
Thank you very much for your answer. With regard to that, I would like to pose a question to Professor Lee. There was this question where in your presentation you talked about the variants of what kind of difference it has with the existing COVID-19, and do we need to change the testing, the way of testing and diagnosis? And also with regard to the self-check kit or the self-diagnosis kit, what's your take on that? Well, we can say that WHO and the materials from WHO is probably the most credible out of the many materials. But in England, if you look at the strain there, from August to September, we saw that strain coming. And in more than 130 countries, we've been seeing the outbreak of the strain that we saw in England. And as I've mentioned, the speed of transmissibility has been going up from 50 to 70%. And in terms of the number of deaths, we've been seeing more severe cases. And the third point that I would like to mention is that early on it was very difficult to identify this virus, because the early self-kits were not able to diagnose or test or screen out the positive cases. Of course, we've seen improvements right now, but we do have those that were diagnosed in the past and those that tested positive, whether they now have antibodies. And based on the testing and the research, the conclusion was the following, where in the case of the strain from England, we can say that when it comes to the response to the vaccine, it really didn't impact greatly the median value. In other words, there was some impact. However, it seems as if it wasn't as strong or effective. However, in the case of the strain from South Africa, the variant from South Africa, we were able to see that when it comes to the median value, it was going down with the vaccine. And we've seen a very quick transmission of the virus. But what we can say is that this vaccine is very different depending on the circumstance or the environment, whether so in the lab and in real life. So it's true that what we have right now is what we can work with, but it can be different depending on real life and in the labs. For the Brazilian strain, there is not a lot of information on that, so we cannot draw a conclusion. However, it's true that transmission rates will be very high, and whether the existing vaccine can impact it or not, well, I do know that there are some preliminary conclusions that it may have an impact. But when it comes to these mutants or variants, some may say that additional vaccination will be necessary. For instance, in Israel, we have been seeing high vaccination coverage. However, when it comes to this South Africa variant, we were able to see that, well, transmission rates were 7 times higher than those that were not vaccinated. Israel used Pfizer's vaccine, but with regard to these new mutants or variants, the efficacy of the vaccine seems to be very low. So a revaccination is highly likely in Israel right now. And second, with regard to the self-check kit or the self-test kit, a couple of days ago, Professor Oh Byung-do, a colleague at our university, and according to his research, the sensitivity and the specificity was assessed. We were able to see that sensitivity was quite low. In other words, it was within the 30% range. So when we do use this in vaccination, it didn't seem as effective. For instance, it's not good at selecting the right patients. In other words, only 30% of the patients, it had only a 30% possibility of selecting or screening the patients that were actually positive, meaning that it's not a good testing or screening tool. That was the conclusion drawn. So it's important to improve the self-check kit going forward. And only then can we expand this out. But right now, for public health purposes, there are so many disadvantages, so it's very difficult to use it right now in reality on the sites. But if we find better methodologies, maybe we can use it in the future, but right now it seems a bit difficult to apply this in real life.
Thank you for your response. The next question is related to the financial response to the pandemic. I'm sure you are all familiar with the situation in Korea, and I think that financial response was mentioned in the presentation from our speaker from Denmark and also Malaysia. So I would like to ask our two foreign speakers about the financial support that is being extended in each of your countries.
Thank you very much for the questions. This is the financial response that extended to the country. Initially, when COVID-19 entered Malaysia, we assumed that we are able to curb the COVID-19 in a short duration of time. But it seems that it stays here. As what you believe that COVID-19 will actually stays with us and will be around us for some time, and maybe forever, as is a virus itself. And the financial response is that Malaysia actually had this first wave, and it does not give much of an impact. But however, when it occurs in the second wave, in which a lot more of cases coming up, and we have to do movement control order in which we had a lockdown. And it gives such a big impact towards our economy. But however, we are able to manage it by our reserve financial, and also for those who are in need, we actually give some assistance for their financial problems also. And we actually we are in the curve of trying to increase our GDP for we are curbing our COVID-19 together. That's why when we actually had the lockdown, we see that we have an impact to our economy itself, and it doesn't give much of a benefit economically. So we have to find a way how to curb that, and by having a very strict sort of standard operating procedure for every procedures that we have, every ministries and every activities that we have, we actually try to educate our public to actually comply to this SOPs, we call that, so that we can open up more economic sectors and to actually stabilize our financial. So in terms of our financial response, so far is done by our Ministry of Finance, and in God's grace, it is actually not worsening and stabilizing, And we hope by opening much more economic sectors, we're actually going to be better in future. Thank you.
네, 감사합니다. 이어서 리나 몰라도 보엘 박사님께서 말씀해 주시기 바랍니다.
Thank you. So as I mentioned in my presentation, in terms of the healthcare system, we've been provided expanded financial support for our healthcare system, and that is, of course, for our regions that are heavily involved with the COVID-19 pandemic handling. The regions are in charge of our hospitals, so that means also that they are in charge of the very critical COVID-19 pandemic, COVID-19 patients. And furthermore, of course, because we've had to allocate resources in our hospitals to the treatment of critical patients, we've had to postpone a number of treatments, of surgery and other things that were not urgent. And of course, we also need financial support for moving that forward, because there is a lump of work in front of us. Furthermore, the state has been providing financial support in terms of help packages of several rounds, and that is of course to affected private companies, small business owners, shops and other private businesses who faced losses because of this complete lockdown. It's compensation in terms of if the businesses have staff employed. There's also an initiative in place in terms of people losing their jobs and having a longer and higher span of compensation for salary loss, and then of course also other areas, for example our culture. We also well aware of our artists and cinemas and theaters and so on. So there are a large number of areas where these help packages have been in place to support during the lockdown.
네, 답변 감사합니다.
Thank you very much for the response. In lieu of time, we'll have to move on to the last question of the day. So it's a question here from one of our participants to Professor Lee. In responding to COVID-19, K-quarantine was very well known and very well received. And in the UK and the US, it was covered extensively by many media outlets. But when in terms of supply of vaccine and the case of the number of confirmed cases, it seems like we're going backwards. So, compared to other countries, Professor Lee, how do you see the current situation? Why do you think that things are not really progressing?
Thank you very much for your question. I believe that some in the audience feel that the situation will come to an end soon. First of all, COVID will continue. There is a high possibility that it will continue to exist. For instance, you may be inoculated, but still be exposed to variants. And secondly, the vaccines that have been developed so far are for severe cases. It prevents pneumonia or death. The vaccinations are not to prevent asymptomatic patients or mild cases. AstraZeneca, if you look at the efficacy, it's over 50%. But the other vaccines have not conducted studies, so we do not have information. So we know that the vaccines, most of the vaccines out there are now target severe cases. But when it comes to asymptomatic and mild cases, we don't know the efficacy. But we will continue to see many mild and asymptomatic patients. So there is a high possibility that infections will continue for some time. And as I mentioned earlier, variants are appearing, and we will continue to see asymptomatic patients. So there is a high possibility that we will have to get regular inoculations like we do for the influenza. So for the time being, I believe that we will have to subject ourselves to regular vaccinations. Currently, we're carrying out contact tracing, isolations, and we are also treating those who have infected. And this was effective in the initial stages of the pandemic. But ultimately, of course, vaccinations are the most effective way to contain the virus. Recently, it is true that vaccination coverage in Korea has been rather slow. But in the population over 65 years of age, and for those who have other illnesses, we have seen that getting vaccinations has dropped the death rate in that population. So the target for the vaccinations at this point is for those who are at risk. And then we will inoculate those who are at less risk of death or severe conditions from getting COVID-19. And then we can expand it to the general public. I think that's the phase, that's kind of the route we need to take. Of course, what is most important is to secure vaccine doses, and then afterwards, quickly administering the vaccine is important. Of course, it would have been ideal if Korea had developed the vaccine, but developing a vaccine, as you know, is not an easy feat. As you know, vaccine development is something that Korea has tried hard for a very long time, but Korea lacks patent technology, and that is why Korea could not develop the vaccine sooner. But if we continue to invest, and if we continue to invest in science and technology, I think that Korea does have the capacity to develop a vaccine. And as I mentioned earlier, the coronavirus will not completely disappear. So we need to secure vaccines for the very far future anyway. So it is true that we may be slow right now, but if we have a strategy in place, if we can purchase and secure vaccines at the same time produce our own vaccines, then that will be the most ideal strategy. What is most important is to carry out the vaccines together globally. As mentioned earlier, Dr. Bohl mentioned this, I believe. No one is safe until everybody is safe, and that is why international cooperation and collaboration is key. And as I mentioned earlier, we will probably have to get regular vaccinations at least for the next few years. And social distancing and wearing masks, I think, will be with us for some time. I think it will be very difficult for us to go back to the way things were. Maybe with vaccinations, we can stop severe cases, but we won't be able to effectively stop mild cases. And that is why we will need to keep up with social distancing and keep wearing masks. And that will be the only way to stop the increase in new cases. So we're in it for the long haul. So I think that vaccinations are important, but the MPIs in place right now are equally important.
Thank you very much for the response. We have many questions, and I know that there is a lot of interest on this topic, and it's only natural that we're interested in this topic. But in lieu of time, we'll have to end it here. This is a very important topic and issue, so I hope that we can meet again at a different setting. I wish you all to stay safe, and once again, speakers and all participants, thank you very much. And to the two organizations, thank you very much for enabling today's international seminar. With that, let me close. Thank you very much.